Hi, this is Dr. Jason Lee, clinical immunologist and allergist practicing in Toronto, Ontario. Hello, and welcome to Lecture 5. Now that we have a solid understanding of the basic science immunology behind allergic asthma, the question is, can we apply that knowledge to our benefit to design better and more effective therapies that may actually potentially be a cure? And the answer is clearly yes. When we are able to design specific medications to the targets that we want, we can minimize the collateral damage that we cause in terms of side effects. As such, this umbrella term, biologics, which is really just a fancy way of saying a drug based on the immunologic understanding of the underlying disease, is now the fastest growing segment of the pharmaceutical industry. As such, they're used in inflammatory, infectious, allergic, neurologic, and oncologic diseases. They may have superior immunosuppressive effects than cytotoxic medications, especially in the area of oncology. Biologics can currently be broadly classified as cytokines, monoclonal antibodies, or fusion proteins, but I don't see why this list can't grow to encompass chemokines and other receptors that may be more inclusive and exhaustive. Some examples of cytokines include interferon alpha, interferon beta, and IL-2. Interferon alpha is used in the form of imicramide, which is currently used to treat BCC, actinic keratosis, and genital warts caused by HPV. Pegylated interferon in the form of Pegatron and Pegasus are used to treat hepatitis B and C. Interferon beta in the form of betaferon is used to treat multiple sclerosis. IL-2 proleukin is used to treat malignant melanoma and renal cell carcinomas. By far and away, the biggest class of biologics are monoclonal antibodies. These are generated by cloning individual B cells and expanding one particular clonal antibody. As such, they have something called the same isotype, idiotype, and they recognize the same epitope with the same affinity, which means they essentially recognize the same target with the same amount of strength and won't really bind to other stuff. Now, an antibody, as you remember, is formed by the constant region and the variable region, which is in both the heavy chain and the light chains. It is easier to manipulate these antibodies and form custom antibodies by using other animals. Now, let's take a step back and give you the history. In the 1980s, someone figured out that if you keep injecting an animal, such as a mouse or a rabbit, with an antigen, remember an antigen is something that can stimulate the immune system to develop a response, that animal will eventually produce B cell clones that turn into plasma cells that produce antibodies for whatever you've been injecting, the antigen. Now, once you fuse this plasma cell with a myeloma cell, you form something called a hybridoma. That hybridoma can now be used to be an immortal source for monoclonal antibodies with the same affinity. There is actually a nomenclature for monoclonal antibodies. So, there is a prefix, which is a variable 3 to 5 lengths in characters. This is followed by the target, for example, VI for a viral target, LI for an immune system target, LE for infectious lesions, NE for nervous system, KI for interleukin, MU for musculoskeletal. The next letter or 2 or 3 or 4 characterizes the source of that monoclonal antibody. If it is humanized, it is given the letters ZU. If it is fully human, it is given MU. A mouse is given the letter O, a rat A, hamster E, primate I, chimeric, which is a mixture of two animals, XI. And the suffix is MAB, which stands for monoclonal antibody. For example, infliximab, INF denotes the variable prefix, LI, the target, which is in this case the immune system, XI, which denotes that it's a chimeric antibody, and MAB. Another one is palivizumab, which is used for RSV infections. PALI was what the pharmaceutical company decided to give it. The VI denotes that it's targeting a viral target. The ZU denotes that it's humanized. And MAB, the monoclonal antibody. Some antibodies are fully monoclonal murine antibodies, which means that they are fully mouse sequence. A chimeric antibody denotes that approximately 25 to 32% of the antibody sequences are mouse or mouse protein sequences. A humanized antibody denotes that 5 to 10% is mouse sequence, so this will get the name Zumab, Z-U-M-A-B. Whereas a human antibody, M-U-M-A-B, will be fully human. Of course, there is also a fusion protein, which is the third category of biologic medications. These are essentially soluble and increasing the half-life of these normally cell-bound molecules. They're fused with an Fc part, which is the constant domain of the human immunoglobulin G. As such, these receptors have a high affinity for the ligands. So if you wanted to mop up, for example, IL-1, you could use a fusion protein such as anakinra. Etanercept is a more well-known version of a fusion protein. It is used to mop up TNF out of circulation. Most people are familiar with inhibitors of TNF alpha. These were initially used for rheumatoid arthritis and then to seronegative spondyloarthropathies, IBDs, inflammatory bowel diseases, plaque psoriasis, and JIA. These medications have their role and are very good for certain conditions, like the ones that I mentioned. However, because these were certainly the first well-used biologic medications, many patients and physicians have fixated on their mind that the side effects of these medications are generalizable to all other biologic medications. I want to state here that this is a complete fallacy and that we should not generalize one biologic for another just because they both happen to be biologics. Remember, each one is a specific target, and because it hits that target, the side effects associated, which are called type A dose-dependent predictable reactions, are dependent on the targets that it's hitting. Another common biologic is used for various other conditions in rheumatology called rituximab. It is also used for some hematologic conditions such as CLL or ITP. This binds the target CD20, which is a marker found on all B cells. You can imagine the side effects that this might cause based on depleting B cells. These are very predictable and dose dependent. And as such, only your physician and you can decide what is right for your therapy. Now, you may be asking your question, were these medications in fact tried for asthma? Because, as I mentioned in the previous lectures, asthma certainly involves pro-inflammatory cytokines such as TNF, and it also involves B cells that produce IgE. The answer is yes. These were in fact tried in various forms of asthma and different grades of evidence from animal to human. However, they were not successful. There are several biologics that may be helpful in treating allergic asthma and asthma in general. We will talk about phenotypes next lecture. There are currently two classes of antibody targets that are used. One targets something to do with eosinophils. The other one targets IgE, which is present in both mast cells, eosinophils, and basophils. I will talk about more of this in the next lecture. That is all for now.